Hey everyone, and welcome to another episode of You've Got the Power. I'm your host, Dr. Jason Deitch, and of course we are here with Chief Medical Officer of the Centeno-Schultz Clinic in Broomfield, Colorado, Dr. Chris Centeno. Happy Monday to you.
Happy Monday, Jason.
Thank you. I know last week, hopefully everybody had a wonderful Thanksgiving, a wonderful holiday, got some time to relax, reflect, hopefully stay away from the politics and all those landmine conversations, but was able to get in touch with yourself. What's going on with you? Maybe you've spoken to people in your family that have health concerns and questions, and maybe you've invited them to watch the show. But today, if you're new here, what this program is all about is giving you the tools you need to make the right decisions about how to heal from your orthopedic injuries or your chronic orthopedic pain. Specifically, a lot of people in the group have upper cervical instability, cranial cervical instability, and today's topic is going to answer questions for many people in that group. What we're going to be asking and answering is the question, how ligament tightening after orthobiologic injections may actually explain how you feel after a Picl procedure. And with that, Dr. Centeno, first of all, happy Thanksgiving, happy December, happy everything to everyone. Hope you had a great week last week. And let's break down really this topic about ligament tightening and how people feel after their procedures.
Yeah, thanks, Jason. So the focus here is trying to talk about how, as ligaments heal, we tend to see some predictable things after orthobiologic procedures. Now, this is going to be today specific to craniocervical instability and the Picl procedure. And one of those things that we see, and I've talked about before, is the honeymoon period. And that is for more patients than not, we tend to see a period where for the first week or two, the ligaments are swollen. And being swollen, they're tighter than they were before. And while the patient may be sore, they're also feeling pretty good to have that extra stability caused by the swelling and tightening of the ligaments. So we call that the honeymoon period. The other thing that you may experience is when something is very, very loose, it doesn't really make all that much noise in the body when it moves. But as things get tighter and as ligaments get tighter, but not fully tight, sometimes things can crack and pop a bit more. And then eventually, as the ligament gets normally tight, that cracking and popping goes away. So there's that mid-phase healing, cracking and popping that some patients can feel as they go from a very unstable joint to a moderately stable joint and not quite yet a fully stable joint. So those are two things to keep in mind that are explained by ligament healing and biomechanics. And I get asked those questions all the time by patients, so I thought we'd boil those down today.
It's a great question, great topic. If you're watching, if you've got questions, that's really what this show is all about, is answering the questions you have about your health, about things you may see and read, whether it's in groups or somewhere else on Facebook or anywhere on the internet. You get your opportunity to ask your questions really directly to Dr. Chris Centeno, someone who I regularly refer to as the Elon Musk of regenerative orthopedics. He sort of was there early on, really breaking the way for this new idea that most people didn't really understand. Don't drugs and surgery do all of that? And the answer is not very well. So if you've got questions, now's the time. Doc, one of the things this makes me think of is that people oftentimes don't appreciate the concept that this is all a journey and a process. It's not an event and a moment in time. So people tend to confuse that issue, and I think don't always understand then what to expect because they think, well, you did it, it should be fixed. I hurt, it broke, you did it, it's fixed. But the body doesn't work that way. Nature doesn't work that way. Oftentimes, it's one thing if you've been in a car accident, you know exactly where you had your specific trauma to cause your injury. But a lot of people earn these over time. And it's the last straw phenomenon more than it is a particular, moment in time. I just bent over like I always do. And boom, this happened to me. Would you elaborate more in detail that people can understand sort of that distinction between, a process of healing versus here's a drug, here's the effect, and when it wears off, it wears off?
Yeah, so I think that's a good point. When it comes to orthobiologic injection procedures, especially involving ligaments, we'll often have a patient on a treatment journey. So what that means is, the first procedure will tighten things down some, the second some more, the third some more, etc. Now that's different than getting a surgical fusion where you kind of get, some bolts put in, and then once you heal from the trauma of that major surgery, you get what you get. So it's a different concept than surgery, and it's one that's a journey, and that journey involves some patient input, right? We can try to tighten down ligaments, but there are muscles that also provide stability that need to be strengthened. And sometimes there are other problems as well that have cropped up that are only indirectly related to the original problem. So all of those things may need to be addressed.
Yeah, and I think you said that beautifully, and hopefully people are hearing is that this is, it's your body, it's your journey. It's not the doctor's journey, it's yours. And the more you know what to expect on your journey, the more you know what your options are on your journey. I'll even say the more you know what questions to ask on your journey, all of these things will guide you. I know most people watching just sort of want, what do I expect? Is it working? Is it not working? Am I on the right path? Am I on a dangerous path? What should I do? Anything else you want to talk about, sort of the tightening, or should we get over to questions that are coming in right now?
Let's go to questions.
Let's do it. We've got Rob Long. Since blood products are cells that work through the instructions from the body, how do the cells know what to do when injected? And he says, parentheses, tightening versus repair or do nothing. It's a great question. How does the body, how do the cells know what to do?
Yeah, so let's review that just for a second. Now, when we talk about blood products, we're really talking about things like platelet-rich plasma. So PRP has concentrated platelets, which really, since they don't have a nucleus, aren't considered a cell. When it comes to bone marrow concentrate, that does have mesenchymal stem cells and other cells in it. So that would be more of a cellular therapy. If we're talking about how, for instance, a mesenchymal stem cell determines what to do, that's a complex thing. But for instance, one of the clues it would look for would be free collagen, meaning collagen that isn't bound in a ligament, but is just exposed to the exterior environment. So that's one clue that it would use to decide what to do. Another clue that it would use would be inflammation in the area, meaning the body has brought in cells to try to clean up the damage. All of those things are used as clues by those cells as to what to do. So there's a number of different things that stem cells, or clues that stem cells can use, including things like chemical clues in the environment, meaning other cells can go and tell stem cells what to do. So for instance, if there were platelets in the area for an acute injury, then those platelets would be releasing chemical messages to the stem cells that are local there. So the answer is there's lots of clues on the ground as to what's going wrong. And in addition, the amount of pressure the area bears is another clue. So for instance, we know that if we put large amounts of pressure on a stem cell, it's more likely to become bone. If that pressure is stretch pressure, then it's more likely to become a muscle or a ligament. Compressive pressure, completely different. So those are all clues that the body uses as to what to do.
I'm going to ask you to dig down. I love this question for a lot of reasons. I guess what I'd like to dig down deeper in, his question says blood products. And so the first thing that comes to mind for me is whether this is autologous from your own body versus some sort of, artificial product that maybe had been manufactured or came from someone else's body. And the thing that so many of us forget, I believe, is that our body has its own cells that it's making each and every day, each and every moment, that does come with the instructions on how to do exactly what you're asking, Rob. That's part of our innate, inborn, natural intelligence, and it's doing it every day, all the time. We take it for granted. That's what keeps us alive, keeps us healing, in most cases, most of the time. Do you want to elaborate more, Doc, on sort of the difference between some sort of, quote, product and the difference between something that actually comes from our own body and is just simply put in an area that just doesn't have as much blood supply, that it's using its own body to heal its own body?
Yeah, so obviously when it comes to someone else's cells or allogeneic products, and there really are no US allogeneic, meaning from someone else, stem cell products, those things are advertised but not real. But when it comes to those things, there's all sorts of things the body does. If it recognizes those cells as foreign, it's obviously going to get rid of those cells because the body deals with foreign invaders all the time and is quite good at getting rid of those foreign invaders. Now, when it comes to your own cells, that's obviously completely different. You could think of it like you've got a barcode on the outside of each cell. They're really called HLA antigens, but let's call it a barcode. And your immune cells have a barcode scanner to try to see if the barcode reads out as my own stuff or not my own stuff. And in the my own stuff category, obviously those cells are allowed to do what it is they're supposed to do. So for instance, we know through platelet-rich plasma studies that taking concentrated platelets from the blood and injecting those into the knee, we now have almost 24 randomized controlled trials showing that helps knee pain. Even though those platelets are coming from the blood and being put into the knee, those platelets still know what to do.
It's a pretty miraculous thing, this human body of ours, and that's really the beauty of it. I think that many of us want to remember is that we have such a remarkable ability and capacity to heal ourselves, and most of the times that's exactly what happens. And it's in these, exceptions that the body's not, for whatever reason, healing to the degree that we'd like to, whether it was from an excessive trauma, or in many cases, whether it's through the micro traumas, your postures at work, or your posture when you're sleeping, or the things you may continue to do because you believe in the philosophy, no pain, no gain, we'll just toughen up through it, only making things worse in many cases. So understanding the miracle of the body and listening to your body. We oftentimes say that pain means to pay attention inside now. And the reason for that is because what's going on inside really does determine and is really the source of the healing that's going to come from you from the inside. So hopefully that makes sense. Let's move on to questions. Great question, Rob. Thank you for that. This was submitted in advance by Harry Winston. He asks, how long shall I plan to recuperate out of work after the PICL procedure?
Yeah, Harry, everyone is different. And in particular for PICL, there's a bigger range than for other procedures we perform. So for example, if we were talking about injecting your knee with PRP, there's a rather narrow range of patient experiences that 95% of patients would fit into. For PICL, that's a broader range. So I would say the average person would take 3 to 7 days off from work after a PICL procedure. Now, we have people that really could have probably gone back to work the day after the procedure or the day after that. And we have people on the other end of that spectrum who have at least a multi-week flare-up from the procedure. So it's harder to judge with this procedure. I would say the general rule is that if you can tolerate injection-based procedures and you've had them before in your neck and they didn't really flare you up that much, then you'll probably be on the shorter side of that estimate. If, on the other hand, you've had other injection-based procedures in your neck and they really caused a big setback, then you'll be on the longer end of that recovery curve.
Excellent, Harry. Thank you for your question, and thanks for always weekly asking so many great questions. We have another one submitted in advance by Charlotte Wilson, who asks, is it possible to tighten the ligaments too much? How do you know how much to tighten them? Great question.
Yeah, so with this, the answer is not really, meaning that at the end of the day, the goal of any of these cells is to repair the problem that they're seeing, and the body then gives a signal, done, and so that doesn't really happen. So for example, let's say that you injured your ankle. Um, if you've got a normal, healthy immune and inflammatory system, that ankle is never going to get overly tightened. Um, Now, it's possible that if you had repeated trauma to that area, that perhaps the ankle could scar down. Um, and so scarring is always possible in patients who have kind of an abnormal response to the stimulus. So what can you do to prevent an abnormal response? That would be keep your systemic inflammation as low as possible. And the only two ways that you can deal with that are either diet or taking anti-inflammatory supplements. So on the anti-inflammatory supplement side, we've got a stem cell support formula. On the diet side, we've got a book that you can read, basically a low glycemic, healthy whole foods diet, rather than the average American diet, which can be very pro-inflammation. So you want to try to do some basic things to help keep inflammation under control as much as possible.
I think this brings up a super question, and you actually said this earlier when you talked about this sort of being teamwork. Like the doctor does something, but it's up to people to engage in the process as well. And when you say, a lot of times people think that it's just a matter of does the procedure work or not. And what they don't really sort of take into consideration is, what kind of car am I driving into the shop? What kind of shape am I in order to determine how well the procedure will work for me specifically. And I know you have the registry that's, I think, the most advanced, most comprehensive data collection of these procedures, anywhere in the world. So there's a lot of people that respond positively, but if you're looking to find out more of like, how do I make sure this will help me even better? What Dr. Centeno was talking about is your opportunity in the matter. How healthy you are, again, if I use the metaphor of a car and going into the shop, a newer car that's been well maintained and that's driven, carefully and appropriately is going to probably not have as much repair, not have as much damage as somebody who is reckless and, abusive maybe to their car, and they bring in that car in. The mechanic may be the same, the tools may be the same, all of that may be the same, but what you're bringing to the table, metaphorically, even literally in this case, actually does matter. So Rob Long has a follow-up, and he asks, with stem cells, is there potential that stem cells can join to create more calcification rather than heal or tighten a ligament? Says thank you.
Yeah, well, there's certainly a possibility that if you've got extremely high forces on the area and an area that's already calcified or starting to head that direction, that stem cells could continue that. Now, in my experience, when they do that, and it's more rare than common, that's again protective in the body, meaning that realize that if you get a fusion, that's what happens, right? We are basically fusing the area down so it doesn't move at all. So in that case, you would get a fusion type effect. But it's certainly possible that could happen. But generally, when I've seen it happen, and the few times it has happened, it's what the body was in the process of doing, and there was no way to stop that train. So if you've already got a lot of bone spurring up here, that's not a net positive for this procedure. And it's one of the reasons why we need to start catching these things earlier, because I've seen people who initially got injured 20 years ago, and by the time we get them, they've got extensive bone spurring in the upper cervical spine and CCJ, and that's not a big positive thing. That's a negative thing as far as what I see on a day-to-day basis.
Again, such an important principle. You know, if the body's calcifying, it's doing it because it's trying to stabilize an unstable area naturally within. We have so many healing mechanisms, innately to our, body and being, that, you just have to understand the timing and the intention of why these things are happening. So great questions. They're really fantastic. Rachel Riggs, regular viewer. Hey, Rachel. She goes, oh, no, I'm late. What did I miss? I'll wait for the playback. Well, hopefully you're watching. We started a little bit earlier, I should say on time today. So, Rachel, once we're over, this will start over. Hopefully you're still watching, and we appreciate you always tuning in and asking you our questions. Let's go to Mark Herbert. Mark says, I don't have any questions today, but I just wanted to thank Dr. Centeno for all the time he has spent answering my numerous questions over the last 2 years. Thank you so much. That's from Mark Herbert.
Yeah, thank you, Mark. Listen, as much as I can, I can't always tell you that I can get to all of these things because I get a lot of different questions. But I try as hard as I can to communicate, because what I found is, especially on the surgery side, many times we'll see a lack of communication from surgeons, right? The average surgery visit is you go in for a couple minutes, you talk to the doctor. Before that, you talk to the PA. After that, you talk to the PA. You're then communicating back and forth with the nurse. You maybe get another couple minutes of the doctor's time at some later date. But communication is really, really critical for patients to understand which end is up, why they're doing what they're doing. And to me, it means a patient that's more likely to recover, one that fully understands what's going on.
Yeah, being well informed and I'll even say at ease is essential. There's so much miscommunication, and it's so common to hear one thing from one part of the staff, something else from the doctor, another thing from somewhere else. And Dr. Centeno's approach is by far and away the best one out there. Let's get direct to the source. So, Mark, congratulations on that. Let's keep on rocking. We have Shanze Khan. With PRP, several folks have said that in the first few weeks, the tissue is delicate. If patients exert too much and re-injure the tissue, it can feel worse and also get the older symptoms back. In this case, do they wait to still wait to let the PRP work, or better to do a new procedure to restart the healing? Says trying to understand if PRP can still be healing even after weeks of tissue is re-injured or irritated.
Yeah, so if we look at how long PRP takes to help tighten ligaments, in general, that's somewhere between 4 and 8 weeks for a cycle. Now, there's still some ligament remodeling that happens after that time. And is it possible to re-injure the tissue while it's still fragile over those first couple of weeks? It is, but realize that it's a two-edged sword, meaning we were built to heal on the move. So if you look at animal models of healing and you try to restrict the animal so the animal can't move, ultimately that animal has poorer healing than an animal that you let do what it wants to do. And if you've ever watched a dog or a pet heal, they tend to go hard or go down hard for a day or 2 or 3. They're not doing much. They're in pain. Their body is telling them not to do much. But the moment they feel able to get some weight on the area, they're doing that, meaning they've got no instructions in their head they're trying to follow. They're listening to their body. And when we do that in animal studies of healing, the animals heal better. So I would encourage you to try to work on threading the needle rather than overprotecting an area. And threading the needle means listening closely to your body, giving it time to heal, but realizing that loading tissue is as important for healing as staying off of it. And it's very much threading a needle in the healing process.
Well said. Such an important point. There is an intelligent adaptation to all of these things, and we just want to give more trust to the body, as you said, listen within to be able to really appreciate what's really going on. All right, Rachel does have a question. She is watching. This is wonderful. She asks, I'm 2 months post-PICL. I use the infrared heating pad on my C-spine twice daily because it feels good and seems to increase blood flow. Is that okay?
That's fine. Yeah, I mean, if it feels good, you can definitely continue to use it. So not a problem at all.
Excellent, excellent. All right, Rachel, there you go. We've got Andy Keller. For those of us on blood thinners, do you require stopping them prior to these upper cervical injections?
Yeah. So if you're on a blood thinner, it's a good idea to stop. Now, it's interesting because we have had patients who can't come off of them. And even with things like bone marrow aspirations, we've been able to manage that. But it is good practice to come off of those blood thinners. The biggest concern would be if there's any bleeding around the epidural space, that, that extra volume that could be taken up by clotted blood could irritate things. So I think it's a good practice to stop those. So you'll want to talk to your doctor about that, which one you're on, whether or not you need monitoring off of it, how many days you should stop it for, when you should go back on. And generally the rule is if you have to stop it, generally you can go back on, right after you're walking out of recovery from the procedure. So there's no need to stay off of it for a prolonged period of time.
Excellent. Thank you for your question. Next question from Munit. I hope I said that right. Hello. Since our last conversation, I have called your clinic and scheduled my PICL procedure for December 8th with you. I wanted to know, would you also be able to address other areas that I need treatment with, such as my lumbar spine and left ankle? And if yes, should I send my MRIs to your office ahead of time, or should I bring them in with me since I don't have my FTF with you till the day of my procedure?
Yeah, so a lot of this is going to depend on how you handle procedures. So as I said before, there's a pretty big variability in how patients flare up from this procedure. So if you are able to tolerate injection-based procedures, and you know that because you've had them before, and they're not something that has really ever flared you up more than a day or two of feeling uncomfortable after the procedure, then we can do multiple areas at one time. Obviously, as long as you know that the more we inject, the more flared up you're going to be. If you're on the other side of that equation, and let's say you get a massage and that'll flare you up for a week, or you had another injection in your neck or other part of your body that flared you up for a month, definitely not the type of patient who could tolerate that many areas being injected out of the gate. So you've got to decide which one of those boxes you're in. And if you're in the box of, you know what, I've got no problem with any procedures anyone's ever done on me, I don't have big flare-ups after procedures, then we can inject multiple areas. We would look at that when you came out. Just bring all of your stuff with you, and we can talk about what makes sense to inject. Excellent.
Okay, so not to submit in advance, but bring for your face-to-face?
Yeah, I think that's the better idea.
Excellent. All righty. Thank you, Munit. I hope I said that right. All right. Sean Zay follows up with, should one take an iron supplement to help with the PRP processes? How many cc's of PRP do you typically inject in a cervical posterior procedure? And also, would be great to know how much blood can safely be taken out for a neck procedure? Thanks.
Yeah, so we do a hematocrit, and we've actually got a blood loss calculator that we use. So what that means is based on the AABB criteria, American Association of Blood Banks, we look at your hematocrit, which is how many red blood cells you have on board per certain density. We look at your age, your weight, your sex, all of that is put into the blood draw calculator. That spits out a number. Here's the safe amount we can take. When it comes to iron supplements, you should only take iron supplements if you've got an iron problem and or have anemia, which would be very, very low red blood cell count. So you should not be taking them routinely after this note.
All right. She does follow up with, thanks for the article on the PRP products. What's the right color for PRP and PPP products? Some providers use more bloody products while others use a yellowish product. Thank you for answering all our questions.
Yeah, so the difference is what's called leukocyte rich versus leukocyte poor. So leukocyte rich, which has a lot of red and white blood cells, is red, looks like blood. Leukocyte poor, which has fewer red and white blood cells, is amber color. And if you look at the data on both of those products, in general, the current thinking is that leukocyte poor, the amber stuff, is better than the red stuff because it causes less inflammation in the patient and it seems to perform a bit better. Now, there's one or two clinical instances where you'll go the other direction, but for the most part, and what we're talking about here, the amber stuff would be better than the red stuff.
All right, great question. Thank you very much. We've got Jalal who asks, have you ever used nerve hydrodissection or blocks to help with problems other than pain? I have jaw twisting due to my contractions of my facial and jaw muscles that start in my neck.
Yeah, that's a harder thing to block, although it may be possible. So, for instance, we've got a patient right now who has a tongue that pulls backwards into the side, and it actually almost strangles him. Seems to be due to the neck, so it might be possible to do a direct motor nerve block to see if we can get rid of it temporarily to identify the source of the nerve irritation. But that's really on a case-by-case basis to try to see if we can get to that nerve or not on the diagnostic block standpoint. So just realize that, it would really depend on us looking at your specific case to see what would make the most sense for you.
Right. Randy Goldstein, now that tourists are welcome back, can you give an update on Regenix Cayman, please?
Yeah, so it looks like everything is thumbs up for restarting Cayman in January. So we are in the process of scheduling those patients for January. And assuming that the Cayman government goes from the policy of we don't want any COVID to the policy of we're going to have to live with this thing, which is what it seems like right now, we'll be restarting. And so right now the game plan is to start in January. I'll have my first clinic again down there in March. And then I'll be going March and November. I won't be doing a summer clinic down there. So yeah, we're excited to see the Caymans reopen. It's been a long haul, almost 2 years. We are feeling good that the Cayman government has started to say, like everyone else in the world has, we got to live with this thing.
All right, we'll see how that all unfolds. We've got Daniel Wren. Is there a correlation between severity and length of a flare-up after PICL and the amount of ligament healing?
It's a good question, Dan. I think within reason, it may be, but we don't often see that direct correlation. So what that means is we've got patients who don't have a lot of flare-up. They do well after these procedures. We've got patients that do have a lot of flare-up. They do well. So I don't see a direct correlation. In general, I would say that if you had a stout, brief flare-up, that you're probably going to do better than someone who had a very prolonged flare-up. But I don't think there's a difference between very little flare-up and a stout, brief one. I think what we really want to see are flare-ups that are relatively brief. Those are probably associated in general with better outcomes.
Right on. Rob Long's got a follow-up. He asks, are measurements, specifically the Grab Oaks and BAI, are these supposed to stay the same on flexion and extension? He goes on to say, sadly, basic radiology has no knowledge of many measurement methods.
Yeah, so in general, listen, the answer is no one really knows at this juncture, meaning that all of these numbers are generally taken off of X-rays, CT scans, or MRIs in a static position. So if it's an X-ray, it's in a seated position. If it's an MRI or CAT scan, it's lying face up. When it comes to movement-based imaging, that's much more new. And so we have standards now for DMX for things like C1, C2 overhang or ADI or other measurements. But when it comes to things like BAI, the distance between the dens and the skull, basically, that's one we really don't know what happens in flexion and extension or what's supposed to. Same thing when it comes to grab oaks. Having said that, I can tell you from having looked at hundreds and hundreds of these images and measured those things like a grab oaks. In general, we would tend to see a grab oaks that gets a little bit bigger in flexion. But if we're talking about major movements of the needle, meaning that someone's grab oaks is going from a 7 to an 11 or 12 in flexion, that's probably abnormal and usually indicative of EDS as well.
All right, great question. Betsy Batts says, because of COVID, didn't get my PICL, and that's backfired on me. And she goes on to say, I have a phone appointment with Dr. Schultz on Wednesday. How long would I have to wait for the procedure?
How long would you have to wait for the procedure from the time you see Dr. Schultz for a telemedicine visit? Say again.
That's my guess is that.
Yeah.
Yeah.
So, I don't know Dr. Schultz's schedule, but I would imagine it's going to be at least 2 months or so. Just realize that you're going, another possibility is always to get put on a cancellation list. And that can oftentimes get you in sooner rather than later if you're willing to be that flexible. Sometimes, obviously, that's difficult to do with a procedure like this.
That's a great question, Betsy, and it's one of the. I'll pause for a moment and let people know. The doctors don't do this because they need more new patients. As you can tell, they're booked out for months and will continue to be. This is really a public service to help everybody really get access to these types of questions. And I hope that spirit shines through. So great question, Betsy, but important for people, I think, to just pay attention to and be aware of. Rob follows up. In regards to imaging, do you have on your website, by chance, what you want to see in an MRI, upright or supine? He goes, i.e., I know proton density is rarely requested, coronal is rarely provided, multi-slice never thought of. This can help us who are offered imaging prior to consulting with you.
Yeah, so there's a number of different issues here. The first is that when it comes to MRI, the standard MRI that most people get is from C2 down to C7. So it doesn't even include this area. There is a specialized MRI that we've got the protocol for, so you can reach out to Carla, my assistant, and she can give you that protocol and everything that it includes. So that's something that the rad tech would do. Then we've got, whether or not MRI is even a good way to look at this. I would say that if you're going to get an MRI, a seated or stand-up moving-based MRI will give us the most information and the highest chance that we'll be able to get to a CCI diagnosis. However, if you want the single thing that's the most likely to get to a CCI diagnosis, it's not even an MRI, it would be a DMX. So always great to see an MRI. We may actually request one because we've got questions about other levels and other things. But just realize that a standard cervical MRI is usually not all that helpful.
All righty. Betsy Batt follows up, and she's actually asking, Rachel, where did you get your infrared pad for C-spine? But Doc, I think you know that answer.
Yeah, so we've got them. And again, people are different, right? Some people love that thing. Other people, they've got so much systemic inflammation, they've got to be careful not to use it too much.
And I think her follow-up question will be, should she be using that in the time period waiting to get in with Dr. Schultz, or is it something she should wait to get till after her procedure?
I think after the procedure.
All right, there you go, Betsy. Thank you for your questions. Rob's got a question, follow-up. This is to both of us. Can you do an episode where you look at scans that show one to be a candidate for PICL? I know many who are stuck with a CDs, poor reporting, and a doctor who won't look further. Perhaps some simple images.
Yeah, I can certainly do that. I think the reason for doing that is probably just to show you kind of what we see and what we're looking for, but it's not so easy to do. So for instance, Carla, my assistant, has been learning for some time how to do these measurements. She's gotten very good at it now, but it took a while to be able to see what it was we were seeing. So just realize that I wouldn't expect you to watch that episode and then from there be able to figure out much other than, oh, this is kind of all the different things they're looking for. But yeah, that's a good idea. I'd be happy to do that.
All right, you'll see that on a future episode. Thank you for the request. And if any of you others have other requests of, ideas for future programs, we take requests. So thank you for asking. All right, Sharon Neeson says, I'd like to respond on Rob Long's question about calcification. It may be hard to answer this question. If one has calcification in the upper cervical area, would you recommend better not to do PICL? Does the degree of instability make sense in this case? We, of course, want to prevent surgical fusion.
Yeah, that's a tough question to answer because it's very individualized. But just realize that at the end of the day, I have a concern when I see excessive calcification in the CCJ. Now, that's probably only a handful of patients. 1, 2, 3% of the patients I see. And, sometimes that calcification can be so severe, Dr. Schultz just had one of these cases, where we can't even get in where we're supposed to get in to do the PICL procedure. So in this case, there was no way to get in from the top at all. We could only go in through the bottom. And we've seen a few of those cases. Sometimes we can reposition the patient to try to get around the bone spur, et cetera. So there are patients who have enough calcification up there where it's just physically impossible to do the procedure, although that's more rare.
I'm going to ask a follow-up on that one. Just for clarity, this calcification is something that does take time, as you alluded earlier. It's not something that just sort of happens instantaneously. So there is an argument to be made that if you feel these types of symptoms of instability, addressing them sooner, as opposed to, as you mentioned, somebody who waited years and years and years, calcification doesn't happen in a short-term process. It happens over the long term. Is that right? And does that encourage people to want to not just hope it'll go away, but give them a reason or motivation to want to do something sooner rather than later?
Yeah, absolutely. So just realize that, we're talking about patients who have had this condition probably for decades. And having said that, you really want to try to get in and get a diagnosis as quick as you can. Now, I recognize that that's very difficult for some patients because, I always say patients in this condition and other rare things sometimes feel like a pinball on a pinball machine. They're going from specialist to specialist to specialist, getting no answers. And that can go on for many years until finally someone meets someone online that says, hey, you might have this, check this out. Regrettably, we've got a problem with identifying these issues within the medical care system. And obviously that's not the fault of patients, that's the fault of doctors.
And that's a really good reason why, if you're watching, if you're a regular viewer, we encourage you to share this opportunity with others for exactly that reason. Most people don't know who to turn to, where to turn to, and most people discover, what we're doing here and what happens at the Centeno-Schultz Clinic primarily through referrals. people just like you sharing their experience, sharing their knowledge, sharing the opportunity to ask their questions live on this show, for example, or reaching out and contacting the office directly to get a personal assessment as to what's going on because of their significant specialty in this area. So for those of you that think, well, I don't want to bother people, I don't want to, impose my views on others. There are a few of you still out there. Now is a good time. This is the reason to really help guide people based on your experience, based on your knowledge. If you have a good enough trust and rapport with them, hey, trust me, go contact the practice directly and make an appointment. And if you don't know them that well, then a great way to get sort of started and exposed is watch the program. It's free. We do it weekly. They can ask their questions directly. But that's the reason we ask you to, share this information with others. I think you probably all can appreciate that nobody has the advertising budget of the pharmaceutical industry, or medical device injury, of which really gives people a very clear sense that drugs and surgery are the solution to most everything. And it's just not the case. So the way most people discover these types of procedures really is through an organic growth process, oftentimes thanks to you. So thank you for that question. This is one of our last, I think. We got Rob Long, who says, finally, and thank you so much. I know you're still young, Dr. Centeno, but what's the expansion of PICL becoming? Other doctors learning and performing. What's the future look like?
Yeah, so just recently we actually focused inward a little bit. We now just have myself and Dr. Schultz performing these procedures for the most part at the clinic, just because we want to synchronize while we're still doing some learning and making some changes. So I think I mentioned more recently that we're going to be going to a dual C-arm system. So that means that we will now have two fluoroscopes set up, one going this way, one going that way, AP and lateral, to try to improve accuracy, maybe 10-15% on cell placement. So we're still learning, we're still making changes. Now, at some point, now the good news is both he and I know how to do this procedure well. So if I get hit by a bus, he's there to teach it. And hopefully we're not on the same bus, otherwise we're screwed. But outside of that, our goal would be to get some significant publications out on this before we start broadening that out too much, because the concern that both of us have seen in our careers many, many times is new procedures seem to do pretty well in the hands of the developers. But if you expand them too quickly before you don't really know enough, they also tend to just go away. So we've seen that all too many times in our long careers, where a procedure was really, really good. It seemed really, really promising. And then someone decided to go and blow it out and teach it to 100 doctors. Those doctors never did it as well, or were never as careful in choosing patients. And then, someone did some research later on, and it didn't seem to work at all, but it seemed to work great in the hands of the guys that invented it. So that's what we're trying to prevent. And while it may mean that in this early phase, there's less people to do the procedure, we'll get there eventually, and we'll eventually have many more doctors doing this. But we also need to make sure that it doesn't die a horrible death and get relegated to the dustbin of medical history simply because we weren't careful with how we moved it out there.
Great point, great point. Sharon follows up with, I know you deal with privacy policies, but could you do a session and show us before and after imaging? Is that something that we could do?
Yeah, that's on. We have those actually on online on the YouTube channel, and that was back when we were doing quite a bit of before and after DMX. What I could do is to try to just go back to Dr. Katz, because he did a number of those for us, and try to pull 6 or 7 of them from there to try to just look at what that is. At some point, once we got to about 10 or 20 of those, we just said, let's not expose more people to more radiation than we have to, even though those were limited DMX studies. So we kind of stopped doing it that way. Again, just being you always want to make sure that you're only taking the risk that you need to. And radiation, we always try to minimize that exposure for everybody.
All right. Pictures are worth thousands of words. So here we go.
But I'll double back with Dr. Katz on that.
Daniel Iverson, we just got a few more, says, do you see any difference in the success rate from patients that get the PICL faster after an injury than those who had the injury for like 5 years and more?
Yeah, my personal belief on that one is yes, but we're still looking at that one. So my personal belief is yes, but believe me, I've had lots of personal beliefs that didn't turn out to be true once we looked at the data. So my personal sixth sense is yes, that's an issue. That if you've had this for 20 years, you're probably not going to do as well as someone who's had it for 6 months. Now, where that cutoff is, I don't know. Is it 5 years, 10 years, 2 years, 1 year? My guess would be it could break down based on a sixth sense, maybe 5 years or longer or 5 years or less. But in order to get there, we're going to have a lot more long-term data where we can break the group down into 5 or 6 or 7 groups and still have enough in each individual group where we have a statistically significant sample.
Yeah, and so important for people to know everybody's an individual, that, data is great, but oftentimes we end up with an average, and it still doesn't.
We do.
That's a guarantee for you.
Yeah, that's the problem with data analysis. It is an average. Yeah. Hey, I'm going to take one more question because I've got a 2 p.m. meeting I got to get on my end.
Well, last one's not a question. It's Rob saying, all caps, I offer my neck for your testing.
Sounds good. Well, guys, thanks so much for watching today. We were talking about how different responses can be explained by different things in ligament tightening. That honeymoon period and the clicks and pops can both be explained. And listen, I try to be here as much as I can. My goal is to try to answer questions about this procedure. You obviously are the one that you're the ones that need to make the decision on what you do, this or fusion. But to be available to get enough questions answered so that anyone who really wants to dig into this can feel comfortable that at least they know which end is up. So thank you for your time.
Right on. Thank you all for watching. Just a quick announcement. We will not be here this Friday. I'll be traveling, but we will be here next Monday. So hopefully you enjoy your holiday season. Hopefully all is well. If you've got questions, you can reach out to the Centeno-Schultz Clinic directly, whether it's through this page or call or contact them through an email or phone. On behalf of Dr. Chris Centeno, I'm Dr. Jason Deitch. Thank you so much for watching. We appreciate it. Bring your friends, bring your family, bring your doctor. We'll see you next week. Have a great week, everyone. Thanks for watching. Stay well and be kind.